CEN Exam Tips. Question 1. A patient with organophosphate poisoning presents with excessive salivation, bronchuria, and muscle fasciculations. The CEN should anticipate: Option A, atropine and pralidoxime, 2-PAM. Option B, naloxone. Option C, flumazenol. Option D, activated charcoal. The correct answer is option A. Atropine and pralidoxime, 2-PAM. Organophosphate poisoning, e.g., from pesticides, causes cholinergic crisis, sludge, salivation, lacrimation, urination, diaphoresis, GI distress, emesis. Treatment includes atropine, to block muscarinic effects, and pralidoxime, 2-PAM, to regenerate acetylcholinesterase. Decontamination is also essential: remove clothing, wash skin. Naloxone is for opioid overdose, flumazenol for benzodiazepines. Question 2. A patient with a seizure disorder is in status epilepticus. The CEN should administer: Option A, lorazepam, Ativan, 4 mg 4. Option B, phenytoin, dilantin, 20 mg/kg 4. Option C, midazolam, Versed, 10 mg IM. Option D, valproic acid, 20 mg/kg 4. The correct answer is option A. Lorazepam, Ativan, 4 mg 4. Lorazepam is the first-line treatment for status epilepticus. It is a benzodiazepine that terminates seizures. If the seizure continues, phenytoin or fosphenytoin is given. Midazolam may be used if 4-access is not available, IM. Valproic acid is a third-line option. Airway management and ABCs are priorities. Question 3. A patient with cardiogenic shock has a cardiac index 2.2 L/min/m superscript 2 and elevated filling pressures. Which finding would the CEN expect? Option A, warm, dry skin. Option B, cool, clammy skin. Option C, bounding pulses. Option D, widened pulse pressure. The correct answer is option B. Cool, clammy skin. Cardiogenic shock is characterized by decreased cardiac output and increased systemic vascular resistance, SVR, resulting in cool, clammy skin, oliguria, and hypotension. This is in contrast to distributive shock, septic or neurogenic, where skin is warm and dry due to vasodilation. Management includes inotropic support, dobutamine, and vasopressors, norepinephrine. Question 4. A patient with a suspected globe rupture should: Option A. Have the eye patched and the patient placed NPO. Option B. Have the eye examined with a slit lamp. Option C. Be given 4 antibiotics. Option D. Be discharged with a follow-up. The correct answer is option A. Have the eye patched and the patient placed NPO. Globe rupture is a surgical emergency. The eye should be patched with a shield, not pressure, to prevent further injury. The patient should be NPO for possible surgery. Ophthalmology consult is needed. Slit lamp examination should be done cautiously if a rupture is suspected. Antibiotics may be given prophylactically. Discharge is contraindicated. Question 5. Which finding is most concerning in a patient with acute abdominal pain, suggesting peritonitis? Option A, rebound tenderness and guarding. Option B, nausea and vomiting. Option C, diarrhea. Option D, fever. The correct answer is option A. Rebound tenderness and guarding. Rebound tenderness, pain upon release of pressure, and guarding, involuntary muscle stiffness, are signs of peritonitis, indicating peritoneal irritation. These are surgical red flags. Nausea, vomiting, diarrhea, and fever are nonspecific and can be seen with many abdominal conditions. CT imaging can help confirm the diagnosis: appendicitis, diverticulitis, perforation, or bowel obstruction. Question 6. A patient with Guillain-Barré syndrome is admitted with rapidly progressing weakness. The CEN should monitor for Option A, hyperthermia. Option B, respiratory failure. Option C, hypertension. Option D, tachycardia. The correct answer is option B, respiratory failure. Guillain-Barré syndrome is an acute demyelinating polyneuropathy that causes ascending weakness. The most serious complication is respiratory failure due to respiratory muscle weakness, diaphragm and intercostals. CENs should monitor vital capacity, negative inspiratory force, NIF, and tidal volume. Intubation may be necessary if vital capacity drops, 15 ml/kg, or NIF decreases, -20 cm H2O. Question 7. Which sign is most suggestive of a factitious disorder, Munchausen syndrome? Option A, inconsistencies in the patient's history and symptoms. Option B, a history of multiple hospitalizations. Option C, unexplained physical findings. Option D, all of the above. The correct answer is option D, all of the above. Factitious disorder is characterized by the patient feigning or inducing symptoms for secondary gain, attention, care. It presents with inconsistencies in history, multiple hospitalizations, and unexplained physical findings. Unlike malingering, there is no external gain. Careful history, documentation, and consultation with psychiatry are recommended. Question 8. A patient with a long bone fracture presents with severe pain out of proportion to the injury, swelling, and pallor. The patient has a cast. Which diagnosis should the CEN suspect? Option A, compartment syndrome. Option B, fat embolism. Option C, osteomyelitis. Option D, DVT. The correct answer is option A, compartment syndrome. Compartment syndrome is a surgical emergency characterized by pain out of proportion to the injury, pallor, pulselessness, paresthesia, and paralysis. The 6 Ps, pain, pallor, pulselessness, paresthesia, paralysis, poikilothermia. It occurs when pressure within the compartment exceeds perfusion pressure, leading to ischemia and necrosis. Immediate fasciotomy is required to prevent irreversible damage. Question 9. A patient with a corneal abrasion should receive which treatment? Option A, antibiotic eye drops. Option B, NSAID eye drops. Option C, cycloplegic agents. Option D, all of the above. The correct answer is option D, all of the above. Corneal abrasion, scratch on the cornea, is treated with topical antibiotics, to prevent infection, NSAIDs, for pain, and cycloplegic agents, to reduce ciliary spasm and pain. A patch may be used for comfort but is not always recommended. A slit lamp examination with fluorescein staining confirms the diagnosis and rules out a foreign body or ulceration. Question 10. A patient with acute stroke has aphasia. The CEN should: Option A, speak loudly and slowly. Option B, use simple, short sentences and allow time for response. Option C, avoid speaking to prevent frustration. Option D, write everything down. The correct answer is option B. Use simple, short sentences and allow time for response. Aphasia, language impairment, often expressive or receptive, in stroke patients requires patience and clear, simple communication. Speaking slowly and using short sentences reduces cognitive load. Speaking loudly is not helpful as aphasia is not a hearing problem. Avoidance limits communication. Writing may help some patients but should be combined with verbal cues. Speech therapy consultation is appropriate. Question 11. A patient presents with preeclampsia, headache, visual changes, epigastric pain, and elevated liver enzymes and platelets. This patient is at risk for: Option A, eclampsia. Option B, HELLP syndrome. Option C, placental abruption. Option D, preterm labor. The correct answer is option B. HELLP syndrome. HELLP syndrome is a severe form of preeclampsia characterized by hemolysis, elevated liver enzymes, and low platelets. It presents with epigastric pain, nausea, headache, and visual changes. HELLP requires immediate delivery to prevent maternal and fetal morbidity/mortality. Magnesium sulfate is used to prevent eclampsia, and delivery is indicated. Question 12. A patient with alcohol withdrawal presents with tremors, hypertension, tachycardia, and diaphoresis. The CEN should anticipate. Option A: benzodiazepines, lorazepam, chlordiazepoxide. Option B: antipsychotics. Option C: beta blockers. Option D: 4 fluids only. The correct answer is option A. Benzodiazepines, lorazepam, chlordiazepoxide. Benzodiazepines are the first-line treatment for alcohol withdrawal, reducing the risk of seizures and delirium tremens, DTs. They work by augmenting GABA, thus preventing sympathetic overdrive. Chlordiazepoxide, Librium, and lorazepam, Ativan, are commonly used. DTs are a medical emergency requiring ICU-level care. Antipsychotics and beta blockers are adjuncts or alternatives but not first-line. Question 13. A patient presents with a bowel obstruction, nausea, vomiting, abdominal distension, and obstipation. Which imaging study is preferred? Option A: abdominal X-ray. Option B: CT scan with oral contrast. Option C: ultrasound. Option D: MRI. The correct answer is option B. CT scan with oral contrast. CT with oral and 4 contrast is the preferred imaging for suspected bowel obstruction, as it can identify the location, cause, and complications of obstruction. Abdominal X-ray may show air fluid levels but lacks specificity. Ultrasound and MRI are less sensitive. Management includes NPO status, NG tube placement, 4 fluids, and surgical consultation. Question 14. What is the most common presenting symptom of acute coronary syndrome, ACS, in women? Option A: crushing substernal chest pain. Option B: atypical symptoms such as shortness of breath, nausea, and fatigue. Option C: radiating pain to the left arm. Option D: syncope. The correct answer is option B. Atypical symptoms such as shortness of breath, nausea, and fatigue. Women, elderly, and diabetic patients often present with atypical symptoms of ACS, including shortness of breath, nausea, vomiting, fatigue, and epigastric discomfort, rather than classic crushing chest pain. This can lead to delayed recognition and treatment. Emergency nurses must maintain a high index of suspicion for atypical presentations. Question 15. A patient who is a minor, under 18, is brought to the ED with a life-threatening condition. The parents cannot be reached. The CEN should. Option A: wait until the parents are reached. Option B: provide life-saving treatment under implied consent. Option C: call Child Protective Services. Option D: transfer the patient to another hospital. The correct answer is option B. Provide life-saving treatment under implied consent. In emergencies, implied consent allows healthcare providers to treat a minor without parental consent when the patient's life or limb is in danger and a delay could cause harm. The CEN should also notify the parents and CPS as required. This is part of the EMTALA requirements. Question 16. A patient presents with a severe headache, fever, nuchal rigidity, and altered mental status. Which diagnosis should the CEN suspect? Option A: migraine. Option B: meningitis. Option C: subarachnoid hemorrhage. Option D: temporal arteritis. The correct answer is option B. Meningitis. The classic triad for meningitis is headache, fever, and nuchal rigidity, neck stiffness, often accompanied by altered mental status, photophobia, and vomiting. Prompt antibiotics, within 60 minutes of suspicion, are critical. LP confirms the diagnosis. The patient should be placed on droplet precautions initially. Empirical antibiotics include vancomycin, ceftriaxone, and ampicillin. Question 17. A patient with hypothermia, core temperature 30 degrees Celsius, is unresponsive. The CEN should: Option A. Rewarm the patient with active external rewarming, e.g., warm blankets. Option B. Rewarm with active internal rewarming, e.g., warm 4 fluids, warm humidified oxygen. Option C. Administer 4 antibiotics. Option D. Defibrillate for VF. The correct answer is option B. Rewarm with active internal rewarming, e.g., warm 4 fluids, warm humidified oxygen. Hypothermic patients with temperatures below 32 degrees Celsius are at risk for cardiac arrest. Active internal rewarming is the priority. External rewarming can cause afterdrop or rewarming shock, peripheral vasodilation causing hypotension. Defibrillation may be attempted for VF, but if the patient is severely hypothermic, the heart may not respond until rewarming is initiated. Management is supportive. Question 18. A patient with stable supraventricular tachycardia, SVT, is not responding to vagal maneuvers. Which medication should the CEN anticipate? Option A. Amiodarone 150 mg 4. Option B. Adenosine 6 mg rapid 4 push. Option C. Diltiazem 20 mg 4. Option D. Metoprolol 5 mg 4. The correct answer is option B. Adenosine 6 mg rapid 4 push. Adenosine is the first-line medication for stable SVT. It is given as a rapid 4 push, 1 to 2 seconds, followed by a 20 ml saline flush. The initial dose is 6 mg. If ineffective, a second dose of 12 mg may be given. Adenosine works by transiently blocking AV node conduction. Amiodarone, diltiazem, and metoprolol are also used for rate control in certain tachyarrhythmias but are not first line for SVT. Question 19. A patient with suspected C. difficile infection should be placed on which type of precautions? Option A. Contact precautions. Option B. Droplet precautions. Option C. Airborne precautions. Option D. Standard precautions. The correct answer is option A. Contact precautions. C. difficile is transmitted via the fecal-oral route, contact with contaminated surfaces or feces. Patients should be placed on contact precautions, gloves and gowns, with hand hygiene using soap and water. Alcohol-based hand rub is not effective against C. diff spores. Private room is preferred. Droplet and airborne precautions are for respiratory infections. Question 20. A patient is in respiratory distress with a heart rate of 120, respiratory rate of 36, and SpO2 of 85% on 4L/min nasal cannula. The patient is anxious and unable to speak in full sentences. What is the appropriate next step? Option A. Increase oxygen to 15 L/min via non-rebreather mask. Option B. Intubate immediately. Option C. Apply BiPAP. Option D. Administer bronchodilators. The correct answer is option A. Increase oxygen to 15 L/min via non-rebreather mask. This patient is in respiratory distress with hypoxia, SpO2 90%. The first step is to maximize oxygen delivery with a high-flow non-rebreather mask, 15 L/min. If the patient does not improve, non-invasive ventilation, BiPAP, or intubation may be needed. Bronchodilators are appropriate for bronchospasm but not the primary intervention in all cases. Intubation is considered if the patient fails non-invasive measures. Question 21. A patient with a known abdominal aortic aneurysm, AAA, presents with acute, severe back and abdominal pain. The CEN should: Option A. Obtain a CT with contrast. Option B. Prepare for emergency surgery. Option C. Administer 4 fluids for hypotension. Option D. All of the above. The correct answer is option D. All of the above. This patient has a ruptured AAA until proven otherwise. The priority is surgical consultation and preparation for emergency repair. CT may be done to confirm but should not delay surgery. 4 fluids should be given cautiously, permissive hypotension, to avoid increasing bleeding. This is a time-critical surgical emergency. Question 22. Which imaging study is preferred for stroke evaluation within the first 24 hours? Option A. CT angiography, CTA. Option B. MRI with diffusion-weighted imaging, DWI. Option C. CT perfusion, CTP. Option D. All of the above depending on the clinical scenario. The correct answer is option D. All of the above depending on the clinical scenario. Stroke evaluation may include non-contrast CT to rule out hemorrhage, CTA to assess large vessel occlusion, CT perfusion to assess penumbra, and MRI DWI for early infarction detection. The choice depends on the clinical scenario, time since last known well, and availability. For thrombectomy candidates, CTA is essential to assess vessel patency. Question 23. A patient with septic shock has been fluid resuscitated with 30 ml/kg of crystalloid but remains hypotensive with a MAP of 55 mmHg. The CEN should anticipate. Option A. Additional fluid bolus. Option B. Initiation of vasopressors, norepinephrine. Option C. Broad-spectrum antibiotics. Option D. Central line placement. The correct answer is option B. Initiation of vasopressors, norepinephrine. In septic shock, if the patient remains hypotensive, MAP 65 mmHg, after adequate fluid resuscitation, 30 ml/kg, vasopressors, norepinephrine, are indicated. Norepinephrine is the first-line vasopressor for septic shock. Broad-spectrum antibiotics should be given within 1 hour of sepsis recognition, and a central line may be needed for vasopressor administration. Question 24. A patient with cyanide poisoning, from smoke inhalation, presents with confusion, dyspnea, and a normal SpO2. The CEN should anticipate. Option A. Sodium thiosulfate and hydroxycobalamin. Option B. Oxygen only. Option C. Naloxone. Option D. Atropine. The correct answer is option A. Sodium thiosulfate and hydroxycobalamin. Cyanide poisoning often occurs with smoke inhalation. Symptoms include confusion, dyspnea, seizures, and lactic acidosis. SpO2 may be normal because oxygen is not utilized by the tissues. Hydroxycobalamin, vitamin B12A, is the first-line antidote, binds cyanide to form cyanocobalamin. Sodium thiosulfate is a second-line agent. Oxygen is supportive. Question 25. Which of the following is the most effective approach for de-escalating an agitated patient? Option A. Use a firm, loud voice to establish authority. Option B. Maintain a calm, non-threatening tone and provide personal space. Option C. Immediately call security for assistance. Option D. Restrain the patient. The correct answer is option B. Maintain a calm, non-threatening tone and provide personal space. De-escalation is a key skill for emergency nurses. It involves using a calm, non-threatening tone, maintaining personal space, acknowledging the patient's feelings, and allowing them to express themselves. Firm, loud voices can escalate agitation. Security may be needed if de-escalation fails, but it should not be the first approach. Restraints are a last resort.